Well, thank you so much. I'm so happy to see the room full. I want to say to all of my new partners, Steve, Trent, and Mark, and Jeff, I'm so happy to be here. And it hasn't taken me very long to realize that New Mexico is probably the best state in the country to be a vascular specialist in. There are so many challenges, not just lower extremity issues. I mean the full breadth. So it's exciting to be here and to be able to follow those things we're passionate about and treat those patients. So, but thank you for coming. So I heard Dr. Hanel use the word sexy in his introduction, and I heard Dr. Prophet use the word lover. And that made me think about the well-established scientific data that says that men that are bald in front are thinkers, men who are bald in back are lovers, and men who are bald all over just think they're lovers. All right? Take that as whatever. Okay? So I know you looked at the itinerary here and said, "Whoa, I'm gonna get a break on that talk," because I know you want to talk about dichrotic notches, reflected waves, spectral waveforms, velocity profiles, and T1 and T2 weighted MRI for 20 minutes, right? I didn't either. So I morphed the talk a little bit into a broader overview of peripheral arterial disease, specifically lower extremity disease, and specifically limb preservation, which we're really talking about people with rest pain, ulcerations, gangrene. So hopefully this will set this in a larger context because you've heard from some experts already and there's more to come. That's pretty distilled. That's some pretty tight information you're getting, like Steve said. I don't think I'm gonna plug anything into the back of anybody's head and download anything, okay? But let's talk about it and see what we can do. You've all seen this. It's time to get to work, right? So when we talk about lower extremity arterial occlusive disease, it's really one of the most challenging disease processes that we face as vascular specialists. 8 to 12 million Americans are affected. The prevalence is high. After you top 70, even if you don't have risk factors or the classic 4, you've lived long enough to accumulate some of these problems, and some of these patients will present with trouble. Arterial disease in our lifetime is increasing. How is that? Because we should be getting healthier, right? Well, our population's getting older. We still have persistence of cigarette smoking. I think the rates have dropped, but it's still a pretty popular activity, especially in this state. All right? Epidemic rates of diabetes, hypertension, and obesity. All of these things keep this process moving forward and growing more and more every year. So yearly, 100,000 patients will have some form of arterial revascularization. That's a lot of folks. So lower extremity arterial disease usually follows kind of 2 slightly separate paths. So if we talk about Rutherford categories, kind of 0 through 3, and yeah, I didn't know there was a 0, but I guess if you have no pain, you're 0, right? 1, 2, and 3, mild, moderate, and severe claudication. Well, these patients aren't at high risk for amputation, maybe 5% at 5 years. Only a quarter of these patients really experience clinical deterioration. So we treat these folks, we treat them aggressively, we love to see them, but they're not the cohort who really show up for limb preservation. It's the other category, and we certainly see a lot of this. Rutherford 4, 5, and 6. So rest pain, ulceration, and gangrene. Critical limb ischemia. Untreated, it has a grim prognosis. We all know that. 40% of these patients untreated will progress to limb loss. 20% die over a 6-month period. So they usually come with at least some, if not all, of the classic risk factors: hypertension, diabetes, hyperlipidemia, some history or ongoing tobacco smoking. And then these risk factors bring along other disease processes that develop over time, like coronary artery disease, end-stage renal disease, obesity. the cardiovascular mortality for our patients with systemic atherosclerosis is high. We all know that. So each of these patients presents with challenges and multiple complex issues to consider. Their pathology, their anatomic distribution, degree of ischemia, availability of conduits for bypasses, comorbid conditions, functional status, ambulation potential, suitability of anatomy for revascularization. So this is like a chess match. And these folks show up and they've plopped down their pieces and you've got to respond. And each one is different. There's no set formula. So we have to use every tool in our tool bag to help these patients get better. Now, there is a small imaging portion of this talk. If you look at this list, we use our imaging, and I'm not going to go over every modality that we have, but the major ones, ultrasound, CT, and MRI, to answer some of these questions so that we can better respond to each patient's unique challenges. So imaging can look at 5 of these areas quite well and help us decide what's our next move. So how are we going to use these tests? So lower extremity physiologic studies. These are waveform studies, pressure-based studies, office-based, Doppler-based, reliable, inexpensive, simple, reproducible. A good measure of global limb perfusion. But they can't do it all, okay? ABIs alone, when they're accurate, with no other information like waveforms, they don't really localize the area of stenosis, whether it's aortic, iliac, femoral, or tibial. And let me say that for our patients with critical limb ischemia, they almost always have 2 different levels affected. It's usually a multi-level disease process. They don't help us plan our revascularization very well, and as Dr. Prophet mentioned, many ABIs alone, especially here, are inaccurate. So this is just a quick example of one of those studies. This is pulse volume recordings out of the office, out of an office. Normal waveforms, nice peaks, dichrotic notches, the pressures are normal. This is an abnormal study. You can see the blunting and the rounding of the waveforms, the diminished amplitudes, and the pressures are down as well. Both of these represent pretty accurate studies, I think, for those patients, and it's a good example of some of the information that you can gain with these. As we said, they're not quite specific enough, so oftentimes patients will go on to arterial duplex ultrasound. It's good at localizing the disease. We look right at the vessel, follow it along. You can see it in color. You can see it in grayscale. You can take a spectral waveform analysis and velocity profiles, which actually is very accurate at identifying blockages and narrowings 50% or greater. So it really gives us a good idea where the disease might be located. It can be cumbersome. Your technologists have to be very skilled at it. Some limitations in assessing the tibial vessels. We can see those well, but we can't get always a complete sense, and really not very helpful if you're trying to decide if there are targets in the feet. We don't use it in that way. So just a good example of duplex ultrasound. There's the color flow, there's a waveform, nice, pretty close to triphasic there. In this one, you'll see a grayscale image with the outline of the stent. Then you'll see the color flow through it, guaranteeing that that stent is patent. So if we go on to CT scan, certainly we use that frequently. It has a lot of advantages. Excellent spatial resolution, rapid image acquisition. You can reconstruct these. It can take some time, but they can give you a lot of data. Calcium obscures the image sometimes and limits what we can see in certain areas. You have to give patients contrast for that often. If they have renal issues, that can be a problem. You can have allergic reactions. Patients have to get radiation exposure, and then image artifact if the patient's moving. Or think post-intervention when we have stents in the way. You scan through that area, you just get a bunch of diffraction, and you don't see much. So this is a big chunk of calcium sitting in the aorta there. I wish I could say that was contrast, but that's calcium. And this is another view with calcium. Same patient, reconstruction, beautiful reconstructed image. And this patient didn't present with critical limb ischemia. He presented with claudication. And CT is very useful for these more proximal blockages. Beautiful reconstruction of this patient's tibial runoff. You can see it's pretty much 3 vessel, but as you get down toward the ankle and the foot, things fade away. It's just harder to make heads or tails of that. He certainly has patent flow in his feet. We just can't see it with the CT. So MRI, we can use that. We've all ordered that, I'm sure. No radiation is one of the advantages. Calcium doesn't really affect the images. And it images some arteries well that other methods don't, tibials and pedals. Disadvantages, inferior spatial resolution, long acquisition times, which obviously we know can be difficult on some patients, especially claustrophobic patients. Acquisition artifact, and then if patients were to inadvertently receive gadolinium, they can have nephrogenic systemic fibrosis. So they're careful about that in patients now. Nice reconstruction of the pedal arches in this patient via an MRI. So best applications for these tests. MRI, I think localization of lesions, especially distally, if that is something that you're questioning. You can also evaluate for osteomyelitis. CT scans, again, lesion localization and revascularization planning. The physiologic tests, the pulse volume recordings, PVRs, PADNET, ABI, segmental pressures. Think global limb perfusion evaluation. Can be very good at that. It can capture collateral flow that you might miss looking with a duplex at one specific artery that might be closed. Well, how's the blood flow getting around? If it's not the normal pattern, sometimes you can't see it. These can give you a good idea about that. Very useful for population screening. And what you'll note is that lower extremity evaluation in the vascular lab is really the only area that still has a mandatory criteria for this type of study. Everything else, I think carotids have gone to duplex and other things. It's just because it can see some things that the others can't. So if you have office-based testing and you get some of these abnormal results and you send them here, we repeat that because we have to. It's a mandatory part of that evaluation. Now we go on and do duplex, so we try to drill down on it further, but it's mandatory. So arterial duplex, we lean on this pretty heavily. Localization of the disease, revascularization planning, and then if you really want the workhorse of the vascular laboratory, for us it's post-intervention surveillance. So once we know what we've done, where we've put the bypass, where we've put the stent, and we can have our technologists look right at it on a serial, a routine basis, and say, is there a problem, is there not? Head off those problems before. We don't want to just wait around and sit and say, well, now it's occluded, let's go back and do it again. Catch it when you can, so we really lean into that. So overall, the judicious use of Doppler duplex ultrasound testing really provides, I think, the most anatomic, hemodynamic, and functional information for treatment and surveillance of peripheral arterial disease. Of course, those other tests are very important as well, but we really lean on the ultrasound. So let's go on and just talk a little bit about intervention, kind of set intervention in a larger context, because you'll see some cases, I think, later and see some examples of the technology that we can bring forward to these patients now, whether it's balloon angioplasty or atherectomy or balloons, other bypasses. So there's a lot to think about. But these patients are multifaceted. We mentioned that earlier. They all need improvements in their medical therapy. I know our colleagues are always working at that, and as are we. These are patients specifically, when we're talking about limb preservation, that are coming to us with rest pain, ulcerations and gangrene. So most all those patients will need endovascular therapy, surgery, or a hybrid. We really try to avoid moving straight into a primary amputation. That is really the very, very last straw, and would only be chosen based on the patient's excessively high risk and comorbidities. So we're going to give them something if they come with those Rutherford 4, 5, and 6 issues. Every major study that's out there agree inferior results for patients with diabetes and some form of kidney failure for both the endovascular and the open surgery. One doesn't perform in a superior way than the other necessarily. We do know also from those studies, sometimes open surgery in some of the trials have had complication rates as high as 40%. So we really have to think about the patient's durability and what they can take and what our expectations are before we go right into an open surgical mode. Vascular specialists get their guidance from the Transatlantic Inter-Society Consensus for Management of Peripheral Arterial Disease, TASC, as we know it, TASC 1, then TASC 2 came out 2007 or so, a grading system for aortoiliac lesions and femoral lesions. I think we kind of intuit that and take that forward into the tibial lesions now. TASC A lesions, simple lesions, get endovascular therapy. TASC D lesions, the worst ones, usually need open therapy. And then the B and C, that's a dealer's choice. Whatever expertise you can bring to the table, if you can do it well, you can treat the B and C lesions with either therapy. So traditionally, patients with rest pain or tissue loss were less likely to be offered endovascular therapy, but recent successes have changed that paradigm. We note the basal trial most often in this, bypass versus angioplasty and severe ischemia of the legs. Basal came out of the UK, randomized, controlled, multi-centered, 450 patients. Kind of a brief summary of the results is that the endovascular group and the surgery group had similar outcomes over the first 2 years in relation to amputation-free survival. After that, the surgery group had slightly better outcomes, year 2 and beyond. But most importantly, there was a high degree of crossover between the patients in the groups. So they didn't just throw you in the surgery group and said, good luck, or the endovascular group. They moved these patients purposefully when the need arose from one group to the other to see kind of how they're going to fare. So I'm going to give you just a quick picture here. You're going to see some much better examples of the interventions that we can do, but this is just classic angioplasty. That's a picture of a patient, patent popliteal. As you come down, you see an anterior tibial artery, just the stump, and then it's gone. Tibioperineal trunk is there. The perineal is really the dominant vessel feeding this patient's foot. Posterior tibial's not doing much. A little bit better view of that. Not, I wouldn't call this a robust tibial outflow at this point. The pedal vessels are patent, okay? They're getting fed through those collaterals in the perineal. You see something happening there. That's a good picture of a balloon and a wire through the anterior tibial vessel. The next one is a treatment with the balloon and the wire down into the tibial vessels, all the way onto the foot. And then, voila, you get a very nice reconstituted anterior tibial. You can see it flowing all the way down to the ankle. This is probably post-treatment of the posterior tibial, because now you notice they're all three in the mix. And then there's flow, direct flow onto the foot. So that was a nice, successful case. So intervention strategy. Patient comes with rest pain, low risk. You really have the option, endovascular therapy or open therapy. Just count up, and factor in all of those different issues that we talked about and say which one's going to fit this patient the best. And one doesn't really preclude the other, but you can choose. Patient comes, rest pain and high risk. Remember that open surgical risk can be pretty high. So probably better to choose an endovascular therapy at this point to see if you can augment that perfusion. If patients come with tissue loss and it's moderate, you still have the option to do one or the other, the one you think that is the best. If the tissue loss is severe, that is the category where often you will resort to open surgery because you can reestablish the maximum amount of flow in the shortest amount of time to really treat that forefoot sepsis or whatever happens to be part of that tissue loss. But again, you can see if you put those two side by side, and I can't, but it's half open surgery and half endovascular surgery at this point. So intervention for CLI in 2016 really would say, and this is out of a supplemental publication of the Journal of Vascular Surgery just last month, a balanced view would acknowledge that both endovascular and open bypass are important means of revascularization and a comprehensive approach to functional limb preservation. So I would say an endovascular therapy and open surgery are no longer considered either or options and have become complementary procedures in the fight for limb salvage. Okay? And you're going to see some very good examples of that as we move forward today. So this is my addendum / editorial, the hopeful future. So if you look at this slide, you're going to see that amputation rates, toe, feet, below knee, have dropped significantly over that time frame. And I think that that's an impressive number, especially if you reflect back to what I said at the beginning, that our rates of diabetes, hypertension, obesity are skyrocketing. So that arc is going up, but we're bringing that down. And I say we, and I mean everybody in here. It takes a whole team. It's the wound care, it's the medical management, it's all of these things together. Everybody has a role to play. And as we all try to hone our craft, we are making a dent in those numbers. That is impressive. This is the cover for that collaboration, which produced a guideline for treatment of, specifically they're talking about, diabetic foot ulcers, but of course we can extrapolate that to what we do because it often, the patients come with the same set of issues. And this is between the American Podiatric Medical Association, Society for Vascular Medicine, and the Society for Vascular Surgery. So, their kind of recommendations, and I put this up because each of you will see yourself in this. You'll find a role or more roles that you'll play in this. We all have a part. Patient education, annual foot examination, diabetes control, A1C is less than 7%. Footwear, the monofilament tests. I like this recommendation. I haven't seen it before. An ABI at age 50 for our patients with diabetes, kind of like going for a colonoscopy, right? Let's get a reading. Let's see what it looks like, and we'll just watch you from there. And vascular risk factor modification. So we are better together, right? None of us have the expertise to do all of these things. Only together can we do them well. Comprehensive wound care, offloading, aggressive and appropriate soft tissue management. We've seen some of that in our talks already today. Clinically addressing the peripheral arterial disease, that means risk factor modification, and then the surgical and endovascular therapies that we can apply for our patients' benefit. So, with collaboration and communication, we can salvage more limbs and enhance the quality of life for our shared patients. Thanks.